So, Dr. Scholz, today we're talking about BPH, so enlarged prostates, and the most common procedure for enlarged prostates is TURPs. What is a TURP? What does it stand for? And in what situation would one find themselves in order to get this procedure?
Well, as most people are aware, prostate glands get bigger with age. It's never been adequately explained why that happens, but it's a reality. Not every man gets an enlarged prostate as he gets older, but at least half the men get enlarged prostates when they get older. And surprisingly, a lot of these men with big prostates don't know that they have big prostates because they don't have any problems. And the big prostate is there, but it does not obstruct urine flow. When it does start to press on the urethra, the passage through the prostate that carries urine from the bladder out the penis, then we start to deal with the whole huge industry of how do we help people with this slow urination, frequent urination. The old surgical standby was to have an operation where they would go up the penis and carve out the inside of the prostate. It's called a transurethral resection of the prostate, or a TURP, or a TURP is the acronym. And it's quite effective. It is not a small undertaking. You have to have a catheter for a week afterwards, and there can be complications of bleeding. Impotence is very rare, but has been reported, and men typically will have what we call retrograde ejaculation afterwards, which means that when they have an orgasm, the semen goes in the bladder rather than out the end of the penis. But in terms of fixing the urinary blockage problem, transurethral resections are very effective.
Is the retrograde ejaculation a problem just in general, like long term? Is it going to affect anything?
Well, I suppose if someone wanted to get someone pregnant, that would be a problem. And it's not dangerous in and of itself. It's just subjectively different for the men who are experiencing it.
Before I get to my next question, I just wanted to remind you that all of the videos on this channel are brought to you by people just like you who have donated to us and helped our cause. If you would like to join, you can do so at pcri.org/donate. Now back to this video on TURPs. In all the procedures that come in with BPH, I think the number one thing I think about as a side effect is the concept of scar tissue. Is that something to be concerned about when it comes to a TURP? And really, what does that look like long term?
Well-performed transurethral resection will remove a large portion of the prostate, and it'll have durable benefit over a long period of time. And for many years, there weren't a whole lot of other options. Now, in the present tense, I tend to see transurethral resection sort of as a last resort when other simpler processes like medications or less dramatic interventions, things like urolift or Resume or prostatic arterial embolization, these somewhat less dramatic, less irreversible treatments are usually utilized by me anyway in sort of a stepwise approach. And if those are effective, and they often are, we end up not needing to do TURPs.
So in this situation when someone does have that pressure on the urethra, are they going to their urologist to get this procedure? Do they have to go to a hospital? Is it outpatient, inpatient?
Urologists handle most of this. There are interventional radiologists that do the prostatic arterial embolization procedure. This is a so-called PAE. And PAE is done in men that have really big prostates. It seems to be effective if the gland's 90, 100 plus cc's, which is more than twice as big as normal. It's an outpatient procedure, does not require a catheter. It's not universally effective the way transurethral resections are, but it is often effective and doesn't involve a catheter and bleeding and all that's associated with a big operation.
When it comes to the effectiveness of a TURPs, what is the percentage likelihood that it'll work?
Oh, I think it's 95%. If the problem was diagnosed correctly to begin with, if it really was a blockage problem, the blockage will be relieved and it should be very effective. Like anything, sometimes urinary symptoms can be allocated or thought to be caused by blockage, but they're not. And so if people are getting up a lot at night to urinate because they're drinking too much water, or they have another underlying problem, infection, or some other undiagnosed issue, then the TURP's not going to fix that. But if the problem has been diagnosed correctly, and this can be done with ultrasounds and uroflow tests to confirm that there is indeed a block at the level of the prostate, then the removal of that block will almost always be effective.
Are there any situations in which getting a TURP procedure would interfere with any type of prostate cancer treatment?
Well, men that have had most of their prostate removed, of course, would not be very good candidates for seed implants, which are placed in the prostate tissue. So if a lot of prostate tissue is removed, a seed implant would not work great. The other thing to remember is doing procedures, including TURPs, after radiation can often be a challenging proposition because the tissue doesn't heal normally after it's been radiated. So if men are thinking of having some sort of radiation to their prostate and have pre-existing problems with a big gland, some of the radiation therapists will advocate having a transurethral resection prior to the radiation because doing it after the radiation might cause a non-healing wound, whereas doing it before the radiation will ensure that everything is tidied up and appropriate, and then the radiation can be done subsequently.
You mentioned the concept that there could be some erectile dysfunction. So when it comes to that situation, in what percentage of men do we expect to see this issue?
With transurethral resections, I think it's well less than 5%. It's rare. It's the trouble with any procedure, and this is why transurethral resections have been down the list of options in my own mind, because we have medications that have reversible side effects. We have less invasive procedures, which I've named already. And anytime you go to the hospital and have an operation, they put you to sleep, there's a small chance that something can go wrong. And so procedures of that nature, I always put last in the lineup for situations where the other simpler procedures have been ineffective.
What type of medications would they give you when you get this type of procedure? You know, a lot of times pain medications come into play when you have an operation, but are there also antibiotics?
Yeah, you'll be on antibiotics for a few days and probably will need some pain medications. You have a catheter in, and they might keep you in the hospital for a couple days because cutting all that tissue can cause a lot of bleeding, and they have to wash the blood through and make sure no blood clots form. It's been a tried and true operation for decades, and when other things haven't worked, transurethral resection usually will get the job done.
Is there the possibility that it could affect, having a TURP, could affect the diagnosis of prostate cancer because you have targeted biopsies, random needle biopsies, will it affect that process?
Well, sometimes when the tissue is removed via a transurethral resection, that's sent to the pathologist just like a biopsy is, and sometimes they'll find prostate cancers in the material. So men can be referred to my office because they had a transurethral resection. No one suspected prostate cancer, but there it is. There's been policies developed over the years because we know that many prostate cancers are low grade, and if it is a low grade variant, it's something you just watch. If it's a higher grade variant, then it has further evaluation needs to ensue. In men that have had TURPs that didn't show cancer, there's not really much of any problem for future evaluations. The periphery of the gland is left behind, so men still can catch prostate cancer, and they will need screening annually with PSA just like anyone else. As we all know now, hopefully, because we've said it many times, the concept of PSA density, where if you remove a significant portion of the prostate gland, the serum PSA will drop. So there's a 10-to-1 ratio between the volume of the gland and the PSA in the blood. So if it was 100 cc gland prior to the transurethral resection, and it's reduced to a 30 cc gland because of all the tissue that was cut out, then the PSA, which would average around 10 prior to treatment, would, in theory, average around 3 after everything's healed up from the TURP.
So today we talked about TURPs and we talked about BPH. The reason we bring this up is because we want to fully inform you of what the procedure is going to be like, the side effects that you can expect, and how to handle it. All of these videos are designed so that you can have better conversations with your medical team. More informative conversations will help you with the outcome. And if you know what to expect, maybe it can help alleviate some anxiety. We're always here for you. If you need help with your particular case, you can visit our website, pcri.org/helpline, and you can talk to our prostate cancer patients who have already been through these types of situations and ask them about their experiences or the experiences of other people. This all helps you gain as much education so that you can take care of yourself. Please remember that you are important, you are not alone, and I hope you have a great week.